Hello.
Yeah.
Yeah, good evening. So how are you all? Long time no speak.
Yeah, all good, all good.
Okay. It's one more person joining. Morris is from your place or?
Yeah, from Kenya.
Okay. Dr. Sally, are you there? Can we start?
Yeah, only that I won't stay long. I have something now.
Okay. So today we thought we'll discuss a little bit about incontinence. So what is incontinence? Can someone define incontinence? And what are the types of incontinence you are aware of?
Yeah, urge incontinence,
Okay.
overflow incontinence.
Okay.
Stress incontinence.
Stress incontinence. Okay. Anything else? Can you have more than one type of incontinence, or is it not possible?
Yes, you can.
Okay, you can have a mixed incontinence. So is it a common problem or not so common? What do you think? What do you recommend? You think it's a very common problem or not so common? So the definition is it's a multifactorial syndrome with involuntary leak of urine. So that involuntary leak of urine, is it common or not so common?
It's
But
common.
do you have a lot of patients presenting with this?
80 years is one of them, yes.
Okay. So it is a very common problem. We'll soon find out how common it is. And as you said, there are many types. So one of the things can be a urge incontinence or stress incontinence or mixed incontinence, overflow, or it can be even just a functional incontinence. So how do you define each of those? What is urge incontinence?
Urge is when you can't wait to reach the bathroom.
Okay, so when you mean that, and it sometimes may not be incontinent also. You can have a severe urge, but we may be able to control it. What about stress incontinence? When does that occur? Is it always occur? Or?
When you leak urine, when you are coughing or having
Yeah.
abdominal, when you are stressed,
Anything which increases the abdominal pressure. So coughing or laughing or if you stress or anything that can lead to. And usually stress incontinence, does it occur in an empty bladder or a full bladder?
Full bladder.
Yeah, it's more common when the bladder is full. Okay, and you can also have sometimes postural incontinence or nocturnal enuresis is a different type of incontinence. And when do you get continuous incontinence?
When the sphincter is damaged.
Okay, that is one cause of any, especially post-URP if there is damage. Any other cause in women?
VVF.
Yeah. So those are the things can be. So, and can you have a continuous incontinence plus normal voiding? Is it possible or it may not be possible? So do you think, can you think of an occasion where you can have normal voiding and also at the same time you can have continuous leak? Okay, I'll give you a clue. It is related to BVF. So what else? Where else can the urine come from? Which other structure is close to it? Okay, I have heard of ureter.
Yeah.
Either the ureterovaginal fistula. Then the continuous leak could be from there. And also from the other, bladder would be normal. So you can have a normal voiding also. So how common is it? From your description of when you see, 100 patients having one or two describe it, it actually is grossly underreported because it can be as common as 1 out of every 4 people. Especially it increases with age. So with age, sometimes above 60, 70, it can be almost half the people can have incontinence. And is it more common in men or women?
Women.
Yeah. There are a lot of reasons for it, because it's a short urethra, and then the pelvic floor is mostly muscular, and very often they're not reported because they're mild incontinence, and a lot of people think it is part of the aging process, so that is why they don't actually report it. And when do you call it significant? See, if it occurs, you say once in a month or once in 2 months also, it's incontinence. So quite a lot of it depends on the quality of life, or how the treatment is dependent on how badly they are affected.
Mm.
So one of the reasons why there have been some studies report only 7%, and some can report as much as 70% of the adults having incontinence. That again, it depends on the criteria that they use for diagnosing it. So what are the risk factors for incontinence? And you can read some of it anyway in the slide, and tell me why do they occur? So how do these risk factors contribute to incontinence?
Yeah, childbirth is important for women.
Okay. So how does childbirth affect it?
Because other than having direct damage to, you can have a
So they
perineal
can,
tear.
yeah. And they can also affect the sphincter. So they can affect the sphincter, and also the whole pelvic floor can become weak because of injury. Okay. So then the same, this thing is, what happens with prolapse? What happens? Why does prolapse lead to incontinence? Prolapse is often associated with the cystocele. Then what happens?
Damages the sphincter.
Okay, it may not damage the sphincter, but then the whole pelvic floor is weak. So part of the voluntary sphincter is the pelvic floor muscles. Okay. And the other thing is, because of prolapse and cystocele, there is bound to be significant post-void residue. So when there is an increased post-void residue, what does it make it prone to?
Infections.
Yeah, so infection. So infections again can cause inflammation. Inflammation causes thickening of the bladder wall, which again reduces elasticity. So there's a lot of factors interrelated. Okay. Then what about irritable bowel syndrome, and dementia and multiple sclerosis? How do they affect the continence?
They call nerve damage.
They can cause nerve damage, they can cause neurovesical dysfunction. And again, why is the bowel and bladder control are quite commonly associated or related? Especially in women, because again, the same problem, because both the sphincters are controlled, the voluntary sphincters are primarily by the pelvic floor muscles. And what about obesity, diabetes, and infection and all that? So if you go through the risk factors, so what you find is that these are conditions which can affect continence, but then it may not be there all the time. So that is the reason that they have various definitions of incontinence. It need not be that every day they had to be incontinent to call them incontinent. So once, and there is a possibility of all these factors becoming less prominent and the continence again to improve. But then the important to understand the exact cause. Okay. So what about the anatomy? So how many sphincters are there?
Internal and external.
Yeah. So how does it differ? See, the detrusor muscle and the internal urethral sphincter are predominantly smooth muscles,
Mhm.
while the external sphincter is striated muscle. What is the difference between the smooth and striated muscles? Generally, the rule of thumb.
Is the nerve supply.
Yeah.
Mhm.
No.
Smooth
So
is basically
general
autonomic,
principle. Smooth
yeah.
muscle is.
Autonomic nervous system.
Yeah. Okay. So the autonomic nervous system, and then striated muscle.
Is somatic.
Yeah. So what is the implication?
Is
The
that
striated muscle is actually you can control,
mm,
while autonomic muscles or smooth muscle, you don't have too much of a voluntary control. The striated muscle is under voluntary control, while smooth muscle is involuntary. You don't have too much of control on that. Right. And what is the speciality of detrusor muscle? The way they arranged there. You've been learning about it quite a lot earlier. So how does it sort of expand? When you're doing urodynamic study, what do you find? From 100 ml to about 350 ml.
mhm,
There is no
4
increase in
times.
pressure.
Yeah.
So the detrusor muscle, the arrangement is such that they can actually stretch about 4 times the usual size without causing any increase in pressure. And the way they arrange again is what you find in urodynamic studies. So we talked about the nerve supply. So the sympathetic predominant during storage, and they involved with continence during the storage time. And parasympathetics more involved by voiding time. And what are the neurotransmitters which are normally there? Acetylcholine and noradrenaline. So which is sympathetic, which is parasympathetic of these two?
Acetylcholine is parasympathetic.
Okay.
Yeah, and the other one is sympathetic.
Okay. So sympathetic, it's easy to remember. It's a fight or flight reaction. So they're the ones related to adrenaline or noradrenaline. So what is stress incontinence? So earlier it is said if you, it's incontinence which occurs when you're coughing or laughing or anything which causes stress. So why does that occur?
Poor pelvic floor.
Yeah. So primary reason is that the weakness of the pelvic floor and urethral hypermobility. The urethra is mobile. So if you look at the structure here, I don't know whether you're able to appreciate the. Can you see the full picture?
Yes.
Okay. So what happens is that if it goes down, then there is the continence is not there. So with this angulation of the urethra is there. So if the pelvic floor goes further down, the urethra becomes more straight. So when is it more likely to leak? When it's straight or when it's angled? What did I tell you? The question is that
He said when
one
it
of
is
the causes of
straight,
stress incontinence, hypermobile urethra. In other words, the urethra is quite mobile because the pelvic floor can descend or ascend. So this, what it does basically is that it alters the angle of the urethra from the bladder. See, the bladder is there, the urethra doesn't come straight. It goes at an angle like this. So when, if it straightens, then there is more chance of leak. Are you able to understand or no?
Yes.
I think a lot of
Background noise.
yeah, background noise. See, the same principle is there in vesicouretic reflex. So how is the continence maintained, or because the submucous tunnel, the ureter comes inside and it opens at an angle. So when the detrusor muscle contracts, it closes. So here also in what happens if it is like a hammock? So what happens when the muscles contract? Will the pelvic floor go up or go down? Go up or down? See, the pelvic floor is has an opening through which the rectum passes, the urethra passes. Okay, and it's attached to the bony structures all around. So when it contracts, what will happen to the pelvic floor?
Straightening or?
No, it'll actually go up. See, it is down like this. So
Right.
the thing that is the pelvic floor, it comes like this. So when it contracts, means it becomes small. So then instead of U-shaped like this, it'll go up. Yeah. So when it flattens, what happens? Already the urethral opening is at an angle. So that angle becomes more acute when it contracts. So when there is prolapse, again, what happens is that it comes further down, and that acute angle is no more there, which adds to the continence. And of course, trauma, surgery, any other neurological problem, and muscular atrophy, all these things will decrease the tone of the pelvic floor, which makes it lax. Okay. What about urge incontinence? When does the urge incontinence occur?
When you have detrusor overactivity.
Yeah. So why does the detrusor become overactive?
Inflammation is one reason.
Okay, inflammation is one, infection is one. Then any other causes for overactivity of the muscles?
Neurogenic.
Okay, if the nerve is affected and the nerve keeps stimulating it, it can have any other causes. So that's classical of if there is an injury to the spine, or if there is the multiple sclerosis or any of those. Any other causes of hypertrophic muscles, or hyperactive muscles? What about in men? What happens? Why does the detrusor become overactive? What happens if there is obstruction?
You get thickening of detrusor muscle.
Yes, this is the hypertrophy of the detrusor muscles. So even bladder outflow obstruction and more hypertrophic muscles are more irritable. So how does this present clinically? In CMG, what happens is that you have unstable detrusor contractions. So normally from 100 to 350 ml, there should not be any contractions. But then if you do a CMG, it'll go up and come down. So how does the patient interpret this? So they have the urgency or desire to avoid. But then what will happen to the tendency after a while? See, all these unstable contractions previously we discussed. No? So what happens to the unstable contraction? Does it remain contracted or does it come down after some time?
It comes down suddenly.
So it slowly goes up, it slowly comes down. So that is the reason that, and unless the sphincter opens when it's contracting, there may not be any urine leak.
Mm.
So you might not always have a leak, but you might have a severe urgency. And after some time, the urgency again goes off because the contraction is not there anymore. Okay. So what are the symptoms of incontinence? So obviously it is an involuntary leak which is there. But of course they can present, they need not always have incontinence. If there is a detrusor, orotic detrusor muscle, increased activity of the muscle, you'll have a severe urgency all the time, but it may not leak. And when do they have a higher chance of leak if there is a hypertrophic detrusor muscle? And how does the patient overcome it? Do you understand the question?
Mm-hmm.
See, the unstable detrusor contraction can occur if there is any problem with the spinal cord, spinal injury, neurovesical dysfunction. They keep occurring at regular intervals. And when it occurs like that, when is the chance of having leak higher? So when is it higher? When the bladder is relatively less full or when it's more full?
More full.
Yeah. So the patient themselves will realize that. So what they do, they keep passing urine frequently so that they don't reach a stage where there is, where there is severe urgent incontinence. Right. And what about medications? There are certain medications which can again cause these incontinence or hypertrophic overactive detrusor. So do you recognize these medicines? Where do you use ACE inhibitors or calcium channel blockers? What do you normally use it for?
Hypertension.
Okay, so you need to be careful with hypertensive because sometimes they present with it. Just changing these medication might help them. And what about sedatives? Okay, sedatives also can make them incontinent. Again, migraine medicines, gabapentin, diuretics, even commonly used painkillers, all these things can cause incontinence. Okay. So when you're clinical examination, what are the things you need to look for? Especially if there is incontinence. So why do you have to feel the bladder, look for palpable bladder? What will that tell you?
Well, it's full, and
yeah. So if there is incontinence, if the bladder is full, what does it mean?
It means it's overflow.
Yeah, it can be overflow incontinence, or it can be even stress incontinence because all these things occur with the full bladder.
Yes. Yeah.
Okay. So then, so you need to associate these symptoms with your suggestions or treatment that you're planning to give. Okay. If there is overflow incontinence, what does it mean? Why does it occur like that?
Because of obstruction.
Yeah, but obstruction, why doesn't it present with the acute painful retention? So why does overflow incontinence occur? So normally if the bladder is full and you're not able to pass urine, you'll have severe pain and discomfort. So why would they have overflow incontinence? So much so that there is leak. So what could be the problems?
Maybe neuro.
Okay, one neurological problem. Okay, then. So that it's a very long-standing obstruction. So it can start with the, say, initially 50 ml post-void residue. It can go to 100, 200, 300. So it can keep increasing the post-void residue because the obstruction is slow. Okay. Any other cause? What about sensations?
Yeah.
So if the patient has diabetes and they don't have any bladder sensation of bladder fullness, they might go into retention and overflow incontinence without actually knowing it. Then what are the other things? What is the cough test Valsalva maneuver will tell you?
Or stress incontinence.
Whether there is any stress incontinence. Okay. So what is the test that you need to do? Why do you do a urine analysis if there is incontinence?
Rule out infection.
Infection, inflammation, all those things can cause. You need to do it. What about post-void residue? How do you do it?
Either with CMG or ultrasound.
Okay. So ultrasound is a little tricky to calculate, but then that'll tell you whether there is any significant post-void residue or not. Then what is the information that the ultrasound will tell you?
It will tell you about prostate size and in presence of a stone.
Okay, talking about ultrasound. So what happens with them? What are the things, information that you can gather with ultrasound?
Yeah, so as we said, you can get information about the kidneys, the ureter, the bladder.
Okay,
size
so
of the
we're
prostate,
talking.
presence of
Okay,
stones.
one is that you can look at prostate. You can look at any stones, anything which can cause obstruction. Do you think you'll be able to find out about the wall? So you can thickness of the bladder wall. Again, you can also see any movement of the blood in real time. You can see how much it distance, whether the hypermotility of the urethra and so on. Okay. And what about the other tests that you need to do? Good voiding. That slow down urine and how much you pass. You'll be able to mention about how to plan the patient. What is fat? What is this? The fat test? And how do you do it?
Yeah. Pad test. I'm not certain, but I'm imagining you put a pad there. And
I'll give you a clue. It is used for stress incontinence to quantify it.
Yeah, then it would mean you just count how many pads between urination.
Okay, so what you do is he asks you weigh a certain amount of pad, weigh a pad, then ask him to wear it, and then go about the routine activities. Then after some time, you wait again when it becomes wet. So that will sort of give you a quantification of how much leak is there. So why do you need the quantification level? Because when you're treating with medicines, you need to understand how it progresses. So you would need that. Okay, so okay. And what about EMG? What will that tell you? They'll again tell you about especially the striated muscle contractions. It can be combined with this dynamic studies, urodynamic studies, along with the EMG and all those things, are quite advanced way of evaluation. So what are the treatment options that are available? So one is that the first thing you need to do is to have a diary. So voiding diaries. So that might help you to optimize the fluid intake. So if the primary problem is getting up very frequently in the night and so on, then you can reduce the fluid intake before sleep. Or if you notice that it's related to caffeinated drinks, alcohol, or carbonated drinks, again, all these cause diuresis. So the bladder becomes full. So the incontinence occurs primarily when the bladder is full. So either avoid these drinks, but if you want to keep having the drinks, to empty the bladder quite frequently. And if you notice they're related to any of the medicines, then you can, if necessary, you can stop those medicines. And another interesting thing is that weight loss can very significantly reduce the incontinence. In fact, they found that in the very large meta-analysis, if you lose as much as just 3 to 5% of the weight, it causes almost 50% reduction in incontinence. So it is a very good motivation for people to reduce weight, especially those. Another thing which can be too, that because of incontinence, they could be depressed and they might start eating more also. So finally, the weight loss is one of the significant way of reducing the incontinence. And what about, have you heard of Kegel's exercise? These are exercises which primarily strengthens the pelvic floor. So if you go to internet and choose, read about it, several exercises which will help you, like horse riding, also keep some bottle or something between the legs and press it. Basic thing is to try and contract the pelvic floor muscles. It can be either supervised, you go to a physiotherapist and ask them to teach you, or you can learn even through internet. Or if you have the facilities to have biofeedback to see how they're contracting. This is probably one of the most useful way of treating incontinence. And of course, they have the other aids like pessaries or tampons and adsorbent pads, which lead to continence. And when coming to medication, because it occurs quite frequently in women, the estrogen creams seem to have a lot of benefit. So how does the estrogen cream help? They improve the elasticity or the quality of the local tissues, especially in women. Postmenopausal, when women, the estrogen levels are low, and then there is atrophy of the pelvic floor and the related tissues. So these things with the local estrogen, they found that it helps quite a bit. On the other hand, systemic estrogen, they found actually makes it worse. And then what are the common anticholinergics we have been talking about? And what is it used for? Whenever we talked about CMG, we were talking about what medicine? Anticholinergics. Okay, the tolterodin, what does it do? Either oxybutynin is the first generation, then the newer medicines is tolterodin. These reduce the detrusor contractions, especially if there is significant unstable contractions. Then you use these medicines. And the newer ones, these have, of course, these are anti-muscarinic drugs, which have systemic side effects like dry mouth, and which makes you drink a lot of water, which makes you pass more frequently. But then there are selective medicines like darifenacin or solifenacin, which are slightly more advanced than tolterodin or oxybutynin. Of course, the newer medicine in this is beta agonists, mirabegron, and also the newer. There are some more newer group of medicines which can be used. And finally, they can also, if there is a stress incontinence, you can do the sling operations, which fixes the pelvic floor up and also makes the angle of the urethra more acute. And there are two ways of doing the urethropexy, which is either with the mesh or without the mesh. And mesh is when does have its complication because of infection and a lot of problems. So nowadays they prefer without the mesh. And of course, the other medicine, other newer medicines are not, therapy is not very useful. And men, of course, we have talked quite a bit of about it, especially the BPH or CA prostate, how they cause incontinence. And one other thing to remember is that if you don't treat it properly, post-prostatectomy, incontinence can be worse than the previous disease they had. They will really hate you if you make them incontinent after surgery. So you need to be very, very careful about surgery, especially for prostate when you're offering. Okay. Any questions? Because I don't think the internet seems to be very, very slow and erratic today. Any questions, or shall we stop for the day?
Yeah. Just wondering, from your experience, post-prostatectomy incontinence is more common with, how common is it with open prostatectomy compared with TURP?
Open, I have not really had many patients. In fact, I have not seen a single patient who come to me with the incontinence after open prostate. Because it will be, unless you very aggressively damage it, you can't damage the sphincter with that. With the way you do it, you go with the finger, in the midline, you go to the creative plane and sweep around. So always, generally, the prostate is beyond the sphincter.
Yeah.
So unless you keep poking straight well beyond it to damage the sphincter, you won't damage it so much in open. But then you have to remember, open prostatectomy is a blind procedure.
Yeah.
If there is significant bleeding, you can't control it. And in many of the surgery places, I had, many rural hospitals, I had quite a lot of deaths which occur because of open prostatectomy. But not recently, this talking about 15, 20 years ago. But with the TURP, it is much more common. And of course, with vaporization, because it's a clarity there, you can see clearly, and you don't generally damage the sphincter. And again, compared to benign, if there is a malignant prostate, then the damage to sphincter is a little more common. Okay, then my internet keeps on going on and off. So I think we'll call it the day today and see you next time. Bye.
All right. Bye. Thank you.
Welcome.